Hi everyone, this is Dr. Monika Dietrich again, and I am so thrilled to be here to discuss classic childhood rashes and GI viruses, because classic childhood rashes is one of my favorite topics. So let's jump right into it. First, we're going to be talking about these classic viral childhood rashes, and the reason why I want to go over these is because it's really important to identify the typical presentation of what this rash looks like, and then be able to connect that presentation to the cause of that rash. These are all very common rashes in pediatrics, and so we'll be going over all of these. And then we'll also be going over some rashes that aren't exactly viral, although most likely post-viral, but very classic in pediatrics. And that includes Kawasaki, as well as MIS-C, which is multi-system inflammatory syndrome in children. And then for the second part of this lecture, we'll be talking about the most classic GI viruses in pediatrics, which includes rotavirus, norovirus, and adenovirus. So let's jump in and get started. So let's start with a really hot topic right now, which is measles, which is also known as Rubella. I put this little symbol up in the corner because I want you to remember this is an airborne transmission of disease. So if you have a child presenting in your office or in the emergency room and you have a high suspicious for measles, you need to be pulling out your N95s. It is an airborne transmission. The prodrome is going to be a high fever, cough, coryza, conjunctivitis. This is what's known as the 3 C's: cough, coryza, conjunctivitis. Your conjunctivitis is bilateral and usually a very watery kind of tearing conjunctivitis. The timing of the rash onset is usually around day 2 to 4 of illness. You're going to have these prodrome symptoms first, and then around 2 to 4 of illness, you'll have the rash starting. It's a very distinctive presentation and really interesting to see when you see it, because you have this rash starting on the face and neck, and it starts out as small maculopapules, and then those maculopapules actually begin to coalesce, and as they begin to coalesce on the head, it moves down the body, and you get individual maculopapules down the body, which then themselves begin to coalesce and become confluent. This is extremely classic for measles, and is a very typical presentation. The other thing that you can see is Koplik spots, which are sort of these bluish, whitish spots that are seen inside the mouth and the mucosa. And so one of the buzzwords is Koplik spots, and then the 3 C's, as we mentioned, and then the cephalocaudal spread. Key associations include pneumonia, which is a potential sequelae of a measles infection and can be very serious. You can also get encephalitis. And then SSPE is a presentation of severe neurological decline that can occur many years following measles infection. The infectious period is 4 days before to 4 days after rash onset, which is what makes measles so dangerous, because oftentimes people are very infectious before they're even aware that they have measles or this classic rash. So measles 4 days before to 4 days after. How are we going to work this up? Mostly with a PCR, and in most places right now that's through your state health, your local Department of Health. You can also do serology, but that's less commonly done. Treatment is supportive. We don't have any specific antiviral medications. You may consider vitamin A supplementation. All of the research that has shown benefit for vitamin A supplementation is in children who are vitamin A deficient in the first place. So in children who are not deficient, which is, I would say, most children in the United States, it's questionable whether it's actually helpful, although as of now, a lot of people are recommending to still give a select dose of vitamin A supplementation in the case of a measles diagnosis. So what are some complications? Otitis media is by and far the most frequent complication following measles. Pneumonia, this can be a viral pneumonia from measles, or it can be a secondary bacterial pneumonia. And this is the leading cause of death in children who have measles. Neurologic complications include this acute encephalitis, which occurs concurrently with the measles infection, usually 1 to 2 weeks after rash onset. And then this very rare, but absolutely present, fatal degenerative CNS disease called subacute sclerosing panencephalitis, or SSPE, which can occur many years after the measles infection and after resolution of the infection. Diarrhea and dehydration. And you can also, in some cases, have a corneal ulceration or blindness. And this is particularly in those children who are vitamin A deficient, more commonly seen in low resource settings. And then you do have this very interesting transient immunosuppression that happens after a measles infection. You have a transient immune amnesia, particularly your T cell immunity. And that results in an increased susceptibility to secondary infections. So not only do you get infected, but for a period of time, usually a few months afterwards, you have this transient immune amnesia, which increases your risk for other types of infections as well. So a very important topic right now is, what do we do if somebody is exposed to measles? So we know that very young children, particularly babies, are at high risk for complications from measles. So what do we do? In all ages, greater than or equal to 6 months, who are immune. And we say greater than or equal to 6 months because that is the first time that we could potentially give a measles vaccination, is at 6 months of age. So any baby less than 6 months of age is by definition not going to be immune. So a child who is immune, post-exposure prophylaxis is not indicated because the vaccine does a really good job of preventing infection. Okay, what about our little babies that haven't had the chance to be vaccinated yet? We administer Immunoglobulin intramuscularly. So this is an IM version of essentially IVIG, but it's an IM Immunoglobulin. And then they do home quarantine. What about a baby 6 to 11 months who hasn't been vaccinated but was exposed? For those babies, they can get the MMR vaccine, so we administer the MMR vaccine if it's within 3 days of the exposure. If it's 4 to 6 days within the exposure, the vaccine really isn't going to do much, so we give the IM Immunoglobulin. All right, and then our last one is greater than or equal to 12 months, and they're non-immune, so they haven't been vaccinated. Administer the MMR vaccine. In these babies, at this point, there is not an indication, if they're previously healthy, to administer Immunoglobulin. However, if they're immunocompromised, that is a recommendation. So severe immune compromise, regardless of measles immune status, regardless of whether they have received MMR in the past or not, within the first 6 days after exposure, you're going to give them IVIG. So this is going to be intravenous immune globulin. And then if this is a pregnant woman who's non-immune, the MMR probably is going to work great for her, nothing to do. If she's not immune, if she's not been vaccinated, then she also needs to get IVIG. All right, so let's talk about rubella, which has been confused before with measles because it has a very similar rash. The prodrome typically is a mild fever. You have posterior auricular or occipital lymphadenopathy, classically. You have rash that you're not waiting for the rash after your symptoms start. The rash actually usually starts around the same time of the symptoms, definitely within 5 days of the symptoms. The rash is going to be a pink, fine maculopapular rash, and it also starts on the face and moves to the trunk and then out to the extremities. Typically, this rash resolves in about 3 days, although that can be variable, but that's why you may have heard the phrase 3-day rash for rubella. So it's much shorter than a measles rash. And then classically, you also have these posterior auricular nodes. Key associations include the congenital rubella syndrome. And so getting rubella in pregnancy is a really big risk. And your infectious period is a little bit longer than with measles. It's 7 days before to 7 days after rash onset. One thing I do want to point out on my little picture here is in measles, the rash does involve the palms of the hands. In rubella, the rash does not involve the palms of the hands. All right, let's talk about parvovirus B19. Also known as erythema infectiosum, also known as fifth disease. So typically in terms of a prodrome, it's very mild, or there may even be no prodrome. There might be a low-grade fever, malaise, headache. You have a slap cheek rash. So this is this classic red rash that looks as if, slap cheek, because it looks as if perhaps somebody was slapped because of the location of the redness. And here's another example of the slap cheek rash, 2 to 5 days later. And then this is very particular. So 2 to 5 days after symptoms start, you have the slap cheek rash. And then after the slap cheek rash, you have a lacy reticulated rash all over the body several days after the slap cheek rash. So you have slap cheeks, days later, a full body rash. Key associations include aplastic crisis, so particularly in children with sickle cell disease, because of course they're going to be more susceptible to this, but even in children without sickle cell disease. I once had a patient present to the hospital with a hemoglobin of 2, a girl, and she had not had any history of anemia. She had no other symptoms. She was previously healthy, and she came in with a hemoglobin of 2. Otherwise, all of her other cell lines were totally normal. And so, of course, we were concerned about malignancy, but we looked for parvovirus, and it turns out she just had parvovirus. And that put her into a severe anemia because parvovirus likes to target those red blood cells. And because of that, you can also get a fetal anemia in fetal parvovirus, and you can get hydrops fetalis. And in adults, it's more common for them to get arthralgias and arthritis. The infectious period is before rash onset. So if a child has Fifth disease, erythema infectiosum, parvovirus B19, they are not contagious anymore once the rash appears. Prior, yes. Once the rash appears, no, they are no longer infectious. All right, let's talk about HHV6 or 7, also known as Roseola, also known as exanthum subitum, and also known as Sixth disease. And the reason why I give you all of these names is because unfortunately they are used interchangeably in questions and in the literature. And so these are all equivalent to each other. The prodrome is a high fever, very high fever usually, for 3 to 5 days. And other than this high fever, the kids are actually pretty well appearing. They might be running around happy, maybe just during the fever kind of puny, but in between doing pretty okay. And then after this high fever, the rash appears. So the fever is going to break. The kid is no longer febrile, but all of a sudden they have this very impressive rash. And what does that rash do? So it's roseola. We call it the rash of roses, and that's because it starts on your trunk, and it's this beautiful kind of salmon pink color, and it expands out. So it starts on the trunk, and it goes out to your extremities, up to the face, down to the legs. Buzzwords is fever first, then rash. If you have a question stem that says this kid came in because they have a rash all over their body, the last few days they had fevers of 102, 103, but now they're completely afebrile. That is HHV 6 or 7 or Roseola. Key associations include infants that are 6 to 15 months. That is going to be the big time period for when kids get Roseola. And typically it's a benign course. The infectious period is during the febrile phase, again, before the rash appears. So after the rash appears, these children are typically no longer infectious. All right, let's talk about chickenpox. And the first thing I want to bring your attention to is, again, I have this little icon up here, which means this is airborne. So if you have a suspicion for a child who may have chickenpox, get out your N95. A primary varicella infection, which is chickenpox, is absolutely airborne transmission and is highly infectious. So it requires airborne precautions, including N95s and hopefully a negative pressure room if you have one. So the prodrome is going to be a low fever, generally some malaise, maybe a pharyngitis, and then on day 1 or 2 of illness, you're going to have this very interesting rash that starts. So this rash begins as sort of little erythematous papules, which then become vesicular and then become pustular. And these vesicles are on this sort of bright red erythematous base. And so that's why we call them a dewdrop, the vesicle, on a rose petal, this bright erythema. The other thing that's important to understand about the rash of chickenpox is that it's going to be in multiple stages in different places at the same time. So you're going to have crops of the rash showing up all over the body, and each of them are going to mean a different stage. So one of them might just be the initial little papules that are not yet vesicles, and then another crop might already be vesicular, another crop might then be pustular, and another crop might then be starting to scab over. So key associations, superinfection is really, really important. So especially group A strep, these kids are at high risk for group A strep skin superinfection. And a classic association is necrotizing fasciitis from group A strep with chickenpox. You can also get a cerebellitis with a primary varicella infection, and pneumonia is also high risk in chickenpox. The infectious period is going to be 1 to 2 days before the rash, and then until all the lesions are crusted over. A classic question on exams is, Bobby was diagnosed with chickenpox. He's feeling better now. Mom's asking when he can go back to school. And the answer is, once all of the lesions from all the different crops on the body are crusted over, he is no longer infectious. Okay, let's talk about hand, foot, and mouth disease. And then it's another association with Kawasaki virus is herp angina, which is the vesicles that are in the posterior pharynx. But hand, foot, and mouth disease itself is going to have, of course, the presentation of the rash on the hand, foot, and mouth, and sometimes also the genitalia. Prodrome, usually there are some symptoms that occur first at the same time with the rash. So this is going to be fever, sore throat, decreased appetite. So typically not much of a prodrome before, but symptoms start with the rash. The rash description, it's going to be usually more vesicular. It can sometimes be maculopapular or even pustular. And there's going to be vesicles on the hands, feet, oral mucosa, and sometimes the buttocks and the genitalia. This is a classic picture of actually a patient of mine who gave permission for use of these pictures. I received these pictures and I said, oh, this is what that is. This is a very classic presentation. And note one thing, look, it's involving the palms, it's involving the soles. There are not a lot of infections that do that. And Kawasaki virus or hand, foot, and mouth is one of them. And here you can see some, you can also see some vesicles in the posterior pharynx. The infectious period is going to be during acute illness, especially with mouth lesions and fever. Okay, so those are, I would say, the classic major viral childhood rashes. So let's talk a little bit about not necessarily a viral rash, but hypothesized to be a post-viral rash reaction. So this is Kawasaki disease, a very classic pediatric rash. Diagnosis requires greater than or equal to 5 days of fever. So the kiddo needs to be fevering for at least 5 days, plus at least 4 of the following. That includes conjunctivitis, it is bilateral, and it is non-purulent. Oral changes, and so the classic oral change is a strawberry tongue, but it can also include cracked lips or mucositis. Extremity changes, usually when I've seen these cases, it's usually some erythema or edema of the hands and feet, so some swelling. And it's always important to ask your patient or ask the parent, is this what their hands usually look like? Or is this swelling that you notice? Because sometimes, especially in little toddlers, they might have, little fat feet or little fat hands. And it's hard for you to tell, but the parents will know. And then a polymorphous rash. This can be variable. It can look like almost anything, but usually it's not going to be vesicles or crusts. And then cervical lymphadenopathy. That's usually unilateral and usually greater than 1.5 centimeters. So conjunctivitis, oral changes, extremity changes, polymorphous rash, cervical lymphadenopathy. These are the classic symptoms for a Kawasaki diagnosis. There is also an incomplete Kawasaki. So this is where it doesn't fit this classic definition, but there's a high suspicion for it. This is going to happen more commonly in very young children, and especially in infants less than 6 months of age. They may not present with all the typical symptoms of Kawasaki. So you want to think about Kawasaki in a child who has a prolonged fever, and they have at least some of these criteria. In that case, you may want to think about getting some supportive labs and looking, do they have elevated inflammatory markers? Do they have a leukocytosis, a sterile pyuria? So what does that mean? That means a UA that has a large number of white blood cells, but no bacteria. Do they have a thrombocytosis? So that's a very high platelet count that's going to be occurring later on, usually in the progress of Kawasaki. Do they have elevated liver enzymes, anemia? And then in those cases, wherever you have even a suspicion of Kawasaki, you want to make sure that you get an echocardiogram, because what is our main concern? It's going to be coronary artery involvement and dilation, leading to possible coronary artery aneurysm. Okay, so this includes the workup, and I highlighted in red some of those important findings that you might see in incomplete Kawasaki. But generally, this is the workup you're going to want to get. And you also want to think about something that we're going to talk about in a minute, which is a very similar presentation, which is MIS-C. And so you want to consider perhaps doing some COVID testing. In terms of treatment, IVIG is the first line treatment for Kawasaki, 2 grams per kilo once. And then aspirin is really important, especially in the cases of heart involvement, because you want to make sure that you're providing prophylaxis for those kids with increased risk. High dose during the febrile phase, then low dose for several weeks, or if there's coronary artery changes. Consider adding corticosteroids, and then you need to make sure that you're repeating the echo in a couple weeks and then again in a couple months to make sure you haven't had interim development of a coronary artery dilation. Another really kind of classic trip up is that you want to delay live vaccines for 11 months after getting this dose of IVIG. And the reason for that is not because it's dangerous to the child, but because they are not going to respond very well to these vaccinations, because all of that antibody that you gave them is going to just soak up these live vaccines, and it's not going to be immunogenic. So you need to wait at least 11 months after treating for Kawasaki with IVIG before giving live vaccinations. And then you'll continue low-dose aspirin if coronary abnormalities persist. Okay, so then let's move on to kind of a very similar syndrome that was a totally new development during the COVID-19 pandemic. A very scary one during that time. And this was multisystem inflammatory syndrome in children, or MIS-C. So this is the CDC case definition for MIS-C. And it requires that all 7 of these criteria are met. The first is that this is a child, which I think is fairly obvious. The name has in children, so less than 21 years of age. They must be febrile. Note here that there isn't a 5-day requirement like there is for Kawasaki disease. It's just a documented fever. Number 3 is that they have severe illness, which is requiring hospitalization or resulting in death. Remember, this is the case definition, so sometimes this is post-mortem diagnosis. Or 4, laboratory evidence of systemic inflammation. So they define that here as an elevated CRP. And then this one is really important. You need to have multi-organ system involvement, at least 2 or more organ systems. So that can include vascular, so shock, cardiac or cardiovascular, which can be a coronary artery dilation, similar to what we see in Kawasaki, but also you can see other findings as well, including just an elevated troponin. Hematologic, which includes low platelet count, so a thrombocytopenia, and then importantly, an absolute lymphocyte count less than 1,000. This is a classic presentation in MIS-C, is a lymphopenia, an absolute lymphopenia. I think almost all the cases of MIS-C I saw had an absolute lymphopenia. Gastrointestinal, dermatologic, so a rash, including oral dermatologic changes, including like a strawberry tongue. And you can also see conjunctivitis. And then criteria number 6 is you need to have at least some evidence that you had COVID, a SARS-CoV-2 infection. And then number 7 is no alternative plausible diagnosis. So this is a diagnosis of exclusion. So what do we do for MIS-C? So one really important thing to think about is because sometimes this presentation can be so similar to Kawasaki, you want to be thinking about both of those conditions. And the workup is going to be actually fairly similar, but it's going to include some of these other things that we typically see in MIS-C versus Kawasaki. So we usually do a ferritin, a D-dimer, IL-6, a procalcitonin, and there can definitely be clotting abnormalities, which is why we do a lot of this workup, coagulation abnormalities. And so we also do PT, PTT, a fibrinogen, do cardiac markers, CBC, CMP. Hypoalbuminemia is a very common finding as well. We do a cardiac assessment, including EKG and an echo. Rule out other causes because usually a lot of the time these children are presenting very ill. And so of course you want to make sure that they are not presenting septic. So you want to rule out any possible concurrent or infectious cause. And treatment is going to be kind of similar to Kawasaki. It's going to be the same dose of IVIG. Do recommend steroids followed by a taper, and then aspirin as well. And anticoagulation is a risk-based assessment. In cases of refractory MIS-C, you might want to consider an immunologic, including anakinra or tocilizumab or infliximab in some cases. And then, of course, while you're ruling out sepsis, empiric antibiotics. Okay, so remember I told you, hey, after we treat Kawasaki, you need to wait 11 months before you give live vaccination. So in particular, we're thinking about MMR and varicella. So this is just a little chart showing how long you need to wait after getting various kinds of immune globulin for various reasons. And so there's just two that I want to point out that I think are important. We talked about the treatment of Kawasaki disease. You need to wait 11 months. But the other one that may be more and more relevant now is after measles prophylaxis. So that's going to be a different dose than we give to children with Kawasaki or MIS-C. And because of that reason, you don't need to wait as long. The recommendation is to wait 6 months. All right, so just a little quiz time. I want you to think about what each of these rashes are based on the presentation. All right. Measles, hand, foot, and mouth, parvovirus. Okay, this one is also cephalocaudal, but not involving the palms. This one has different crops showing up all over the body at different stages. And this one is blooming out from the trunk out to the extremities and face. We're dealing with rubella, varicella or chickenpox, and roseola.